Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Purva Rawal, former Chief Strategy Officer at CMS Innovation Center, about raising the bar in value-based primary care payment. Let's get started.
Hello, Dr. Dan. How are you doing?
I'm doing well, Faisel.
It is so nice having Purva Rawal with us today.
Thank you. Thanks for having me.
You know, when you think about the decade of primary care across the country, what's one of the most exciting possibilities that you see?
Oh, that's a good opening question. I thought I'd get some kind of a softball to start, but we're going to dive right in.
Oh, well, this is like, we're having such fun times. I mean, it's amazing.
We are.
With all the craziness, there's a lot to be excited about.
Yeah, I agree. I think there's a number of things. I obviously my time, I've been working in the primary care space and with the family physicians on and off for like 10 years. And sometimes it feels like Groundhog Day, and I bet it does to a lot of your listeners who are like in the trenches working on primary care issues. Like, oh, we're still talking about this. We're still not getting paid enough under the fee schedule. But every once in a while, I have to take a step back and think about the progress. And I think there's like growing kind of realization. We're embedding concepts in terms of like what supports advanced primary care, whether it's hybrid payments, prospective payments. I think there's greater and more bipartisan agreement about investments in primary care. I think we're seeing CMS continue to move even under this administration. We did some work last year on the advanced primary care management codes. I think we're seeing, continued movement there in terms of how we can, raise the bar in the fee schedule. And I think there's a real focus on prevention. Right. And moving upstream, I think that has kind of become part of the national conversation, which I think, honestly puts a spotlight on primary care and what it means to communities. Like you said, though, there's a lot of stuff happening in the environment, but those are the things that really make me hopeful. And, I've been doing more work outside of the U.S. as well on primary care and value issues. And there are so many places that are grappling with the same issues that we are. And many of them are looking to things that we've tried here, even if we haven't been able to scale them as quickly as we have wanted to. They are looking at a lot of what we've done around advanced primary care models and ACOs here as well. So that gives me hope that, we'll kind of continue to chip away and get primary care to be valued differently. I think the other thing that makes me hopeful is this acknowledgement around team-based care, that when we have primary care providers and practices embedding social workers, community health workers, having a team-based approach elevates the practice, elevates the work of the family physicians and the primary care docs, and really meets the community's needs. And I feel like that is, we're not where we need to be, but it's a very different conversation than I think it was 5, 6, 7 years ago.
How are you seeing these other countries capture medical complexity?
I have not seen one that has as complex a risk adjustment scheme as we do. Most seem to be, I'm not an expert, in terms of other countries' risk adjustment strategies, but, most of the ones that I have looked at are either pretty nascent in how they're starting to account for medical complexity, or they're just doing it in much simpler ways than we are. And hence, honestly, they're probably less gameable as well. There's just not as many kind of dollars at play. But most systems are, and even developed countries and OECD countries, they're not using the kind of complex methodologies that we are. So, I'm sure there's upsides and downsides to that, but there is something, and I think probably simplicity there.
Since you're looking at what other countries are doing, and I know we often talk about that in the U.S., we're the leader in cost and we're not the leader in quality outcomes, but there are a lot of things that we do well here. I was just thinking about this because I was watching an episode of Ted Lasso and he was picking somebody up from the emergency room and he was just so excited because the person didn't have to pay a bill at the emergency room. And that's obviously not the case here. But I know people are struggling. Healthcare providers are struggling in other countries as well. So what are we doing well here that we could share with other people?
I think many times some of the things that we are doing well are some of it's technology related. I think there is a lot more innovation when it comes to technology. I think we're on the forefront of a lot of that. Now integrating that into practices in a way that, doesn't disrupt workflow, isn't just, adding cost, but actually supporting productivity and reducing burnout. I think those are all the questions about how well a technology works. But those kinds of innovations and technology use, I think we often are ahead of the game. I think sometimes organizationally too, in the sense that, we have a long history here of testing advanced primary care models and ACO models, and even those countries where on the financing side, they're ahead of us, right? Because they're investing more as a percent of their healthcare spend in primary care, or they've already gotten to, more prospective. And I know the word capitated is not a happy word, but prospective payments, right? Where you're kind of giving more flexible payments to primary care providers. Even if other countries are doing some of those things, they haven't necessarily, created a, truly kind of medical home or advanced primary care functions around those. I think the other place where we're probably ahead is really thinking about reducing acute care utilization and moving, right? Knowing that we don't need to be as hospital heavy about a lot of the work that we do. We can move that into ambulatory settings and into primary care clinics, connecting people from that are being discharged and really understanding that care transition from the ER, like you're saying, Dr. Dan, or coming out of a hospitalization means, a warm handoff in coordination with primary care. I think those are things other countries are trying to figure out how to do that. It may not be happening as well as we want it to, but it's definitely part of the standard of care here and something that we increasingly expect for patients. So just a few examples.
And you brought up the different models, and I think I've got it right. A quote that I've seen attributed to you, and I think it's true. It says, "We need to stop treating models like experiments and start treating them like infrastructure." When we stand up all these different models of care, you get a model where you're, whether it's the CPC Plus or one of the innovation models where you go out and hire additional team members, and then all of a sudden you find you don't have funding for that team member 2 or 3 years down the line. What are your thoughts? How do we do that as a culture? How do we say, yes, primary care is important. We need to support these things, and maybe there are tweaks to the models, but we don't wholesale have a model and then it goes away and, oh, well, let's try this new model now.
Well, first, I don't remember saying that, but it sounds really good. So I'm glad. Take a little credit, I guess. Thank you. Yeah, that's a really good point. So I think one of the issues, at least from my time working in this space and then also being at the Innovation Center, is that oftentimes, you have a new model and you're testing the entire model every single time. And when the model ends, like I was saying, the infrastructure goes away. And I'll give you a really concrete example. I was giving a talk earlier this spring at an academic medical center, and one of the folks that asked a question at the end of my talk was actually overseeing a number of primary care first clinics in their region. And so, some of your listeners you both are familiar with PCF, Primary Care First. It was scheduled to end, I think, at the end of 2026. It's going to be ending early. And when I was at the Innovation Center, we had started to think about, well, what's the glide path? Like, this is not a model that's going to be certified, but we know that there's infrastructure here. Many of these practices want to stay in value-based care. So what's the off-ramp for them from this model to be able to maintain the care delivery infrastructure? A good example is the behavioral health infrastructure that a lot of those practices have built. Those are now services those are members of their team, and then those are services that they are offering to their patients. Unfortunately, this doc said that because PCF was ending, they didn't know what the glide path off was, and they didn't know that there probably wasn't going to be another follow-on model. That's one way of carrying infrastructure forward, and so they were going to have to start to take those services down and not offer them. And it was kind of heartbreaking. I'm a psychologist by training, so heartbreaking to hear, because that's sort of the ideal, right? You've now brought behavioral health into primary care. You got these teams working together and you're really treating the whole person. You're not, we're not dividing up all of these different, conditions or situations people are in. And to hear that, you built it, you had the funding to build it, and now you got to take it down. It's just not the kind of innovation we want to see. That's what we want to preserve. And so I would say a couple of things. One, the model tests are really important, but there are certain things that we know work at this point. And even if we don't have, the randomized controlled trial to say behavioral health integration is good, we know that it's better for patients. We have enough evidence directionally to tell us this is a good thing to be doing. And so even if it's not inside a model, we have to find other ways of scaling it, whether that's through the fee schedule, whether that's through, permanent ACO programs, whether that's, pushing in the next round of physician payment reform for permanent ways of doing this for primary care, just kind of raising the bar, raising the floor for everybody. So I think some of those things, it's kind of like you look at the whole model, but look at different pieces of it. It could be that, the hybrid payment might be the thing that you're really testing, not the fact that, behavioral health integration is a good thing. And I think looking at not just the entire model, but the different components of it, and then thinking about how you scale those individual components, I think would be really helpful in preserving that kind of infrastructure.
Was that physician group, were they looking after underserved populations in their model?
That's a good question. I'm not sure. It was urban, so I assume they are catching, more underserved populations. So that's a good question. But I assume so, where they were.
You've seen all these models. You've seen these models succeed. You've seen them stall. You've seen them change, especially with the underserved neighborhoods when you had like all this rush of groups going in to these underserved neighborhoods, opening up centers with the full risk value-based care model, and then having the rules change. I feel for the populations of people who benefited from that. Like, it's like what you said, you have behavioral health is integrated into primary care is into behavioral health. You walk them down. You're not worried about the billing. You're just worried. Your concern is just helping.
Yeah. And I think you're bringing up a really important point that, especially where we're trying new things and innovating in areas that have been historically underserved, a 5-year experiment isn't, going in and then pulling out isn't necessarily what a community needs. Now, on the other hand, the innovation center, the nature of it is to test, right? You can't just go scale things that aren't going to work. But I think we can do a better job of figuring out the pieces that work. And at the beginning, we can be, intentional about how to scale pieces of what works as well. So one of the things that we had tried, it's another model that's ending, is the Making Care Primary model, was on the front end really thinking about multi-payer alignment, for instance, right? We know that, Medicare fee-for-service is just one piece of what a family physician or primary care doc or practice is seeing. And in fact, it's not the vast majority, right, if you look at their payer mix. So if Medicare fee-for-service and the innovation, and CMS is going to come in and say, hey, we want to do this 10-year experiment. And part of that was 10 years because it's like, let's give, people are making an investment. You're not really going to start to see any of this quote unquote payoff till years 4 or 5. Let's give everybody a longer on ramp and some certainty that if they're going to invest in the infrastructure, it's going to be here for some time. But the other key piece of it was we wanted to go in and work with states and state Medicaid programs on day one. So they had agreed to come into that model because we thought it was really important and it takes time to do that we build an aligned value-based payment model, both with Medicaid especially, and also with commercial payers. And there was pretty significant regional commercial payer interest in that model. So there are other ways of saying, look, even if, Congress hasn't given CMS the authority to scale something via regulatory means, there are other ways where you can demonstrate effectiveness with other payers that have other flexibilities. And especially when it comes to primary care, where the payer mix in many cases is heavily Medicaid or, commercial, those kinds of changes like the behavioral health integration can take root through other payers as well.
Like, why is multi-payer alignment just so hard to achieve? Like, what's the boldest step we would need to take to finally get us there?
I don't know if we'd ever figure out that we actually got there either, because it is so complicated. I think this is, and I'll quote, actually, since you're quoting Dr. Dan, I'll quote Liz Fowler, my old boss now, but, she said this was like one of the toughest things that, we encountered at the Innovation Center, and we weren't the first ones to try to do this. We tried to, we were starting to pilot a different approach, but multi-payer alignment, I think over the course of the Innovation Center's time has been one of the toughest nuts to crack. Everyone's tried it kind of different ways. I think it's important to look at multi-payer alignment from the provider perspective, even though it's the payers that kind of hold the keys, right? You need the payers to agree on different features of multi-payer alignment, but figuring out whether or not it's actually meaningful to have that alignment, I think you have to look at it from a provider perspective, like what is making this so difficult for providers? And so one of the things that we had been doing is, and a lot of this work happened with the Healthcare Payment and Learning Action Network as well, was this concept of directional alignment and thinking about, you don't need to, if you have a new payment model, you don't need every payer to be saying, we're going to, pay exactly the same way and the same amounts, and we're going to do risk adjustment and attribution and everything in the same way, because that can be really restrictive. What works in Medicare fee-for-service may not be what's working in Medicaid or for a commercial payer. But if you look at the pain points for the primary care providers, number one, you guys can tell me, but quality measures, right? Like, I got to do all these quality measures like 5 different ways. And on an average, a practice has 7 different payers that they're dealing with. So step one from our perspective was, after hearing from providers, well, can we get quality measure alignment at least? So I'll give you a concrete example. In Making Care Primary, our team spent months coming up with a quality measure list that they had crosswalked with Medicaid and Medicaid colleagues in the states that we were talking to about coming into the model. Crosswalked it with marketplace measures and commercial measures to try to come up with a set that cut across enough that we could get both Medicaid and commercial alignment or interest with. So that's one concrete example. It takes a lot of legwork, but if you can say, look, as Medicare fee-for-service, we're going to, and everyone's not going to get everything they want, but is it enough? And if you do that, that's a win, obviously, for the providers, but it should be a win for all of those payers too. And then as you get quality measures down, then you can start to move to some of the more complicated, even though that's complicated enough, some of the more detailed and complicated kind of features that you want some alignment around. You might not get, for instance, like, if we're going to say in a value-based payment, like, construct, I'm just making a number up, but you're going to get like $100 like for every patient that's in this model. Everyone might not agree on that $100, but we could say, no, if you're in this program, Medicare will give 100, maybe Medicaid is like giving 90 and the commercial payer is giving like 100 or 105 or something. But we can say we're committed to the PMPM. The amounts might vary, but we understand the importance of that prospective kind of stable cash flow coming into the practice.
And part of this is learning new ways to do things and unlearning the old ways. I know back in my past, I helped implement Epic at a large teaching system, and we were doing it straight from the beginning and got to
you're still standing.
I am. And actually, they didn't run me out of town. But the thing I realized after you got to make all these decisions about how you were going to use the system, and it was really cool. And then I remember very clearly, I don't remember the exact problem, but we needed to make a change. And I realized once people learned a way to do it, and you were asking them to change it, it was a whole lot harder than it was in the beginning, getting them to learn the new way. It's sort of like, why is the U.S. never gone to the metric system, right? We still use the English measurement system, even though it's much harder for third graders to understand. And so what do you think is the biggest thing we need to unlearn in this country to help us go forward in improving this multi-model, multi-payer, equitable health system? Just sort of a dream question there.
What's the thing we have to unlearn? I think we have to unlearn fee-for-service as a default. I think that is the default. And there's probably different ways of coming at this, and I think we're seeing some opportunities and some cracks here. But we know that when it comes to primary care, it's almost like a public good, right? In the sense that you guys know the data, your listeners know the data, so I won't go through it. But if we understand and we've empirically proven its value, and we know that the foundation of how we pay for healthcare services doesn't work, then we've got to be okay moving away from it. And it's not going to be perfect, but we have to move away from it. It's almost like sometimes a security blanket. And so we have other, there are other data to inform what primary care services, how they can be paid. The new primary care flex, the ACO model that got going this year, they're using a different, they've got I'm going to botch it, but like a county base rate for, kind of a capitated payment for primary care services. And some of the questions are, well, how do you value telehealth inside of a bundle payment? And as technology is changing, care delivery is changing in primary care, how are we adjusting the way that we're paying for things? My guess is it's not going to be perfect the first time around. Nothing is perfect, but getting ourselves and building the muscle and muscle memory to get away from the way that we are used to billing and valuing services, especially in primary care. I think it's a tough thing because it's like entering the unknown, but I think it's, probably time for a more like radical change in how we're doing some of these things.
So if you could redesign one aspect of the Medicare physician fee schedule to better support innovation, I know we talked about getting rid of fee for service, but what would be the aspect of the physician fee schedule that you would redesign to better support primary care?
So a couple things, and I don't know that it's like getting rid of fee for service as opposed to knowing that it's like not a one size fits all, right? It's better suited to certain specialties than others. And I think the AFP has done some work here. And if you talk to like Bill Shao and like people that were sort of first, obviously set up the physician fee schedule, it was never supposed to be like a really great fit for primary care. A couple things, and I'm not an expert here. I know enough words like to be dangerous, but so don't ask me like details on data. But one thing is definitely like the inputs, right? The way that the inputs coming in to how we value primary care services. And I actually think we're seeing some openness, especially in this administration. I think there's been some great work that the National Academy of Medicine Standing Committee on Primary Care has been doing as well. They've had a number of meetings over the last few years where I think they're doing some really great work. I think there's been some references in the physician fee schedule as well to saying, look, we're open, help us think about other data sources that help us value primary care better. So the radical answer I gave you before is like, I think we should really ideally overhaul the way that we pay primary care, and the fee schedule may not be the best mechanism for paying primary care, and maybe it was never intended to be in the first place. And, but the second answer, like, within the construct that we're working in, there's a lot of opportunity to improve, within the construct. So incremental change is, often much more possible and can yield very good results too. So one is kind of the data that goes into evaluation. And again, I think we're seeing some openness right now to people wanting new ideas, and an administration that's honestly willing to do things differently, I think creates some opportunity. And then I think the other thing is we had started some of this when I was at the Innovation Center working with our colleagues in the Center for Medicare. References, I think, early on were those new advanced primary care management codes. And that's a lot of work that's behind the scenes has been happening. And I'm hopeful that it continues to happen between the Innovation Center and the Center for Medicare, that even in the absence of legislative change, how far can you go in the physician fee schedule to kind of create more consolidated codes that value the coordination services that primary care practices are providing. And so year one was really just like a toe in the water. Like, how do we do this? And I'm sure neither of you, at least I hope neither of you, nor any of your viewers read the entire, the preamble, last year's physician fee schedule, but there was a lot of history there about the learnings from all of these different models, right? That come, they go, new ones start, you get follow-ons, and it cataloged a lot of the learnings around, what are the components of advanced primary care and what is the structure of payment that supports more, team-based care and kind of helps to account for all of those non-face-to-face and care coordination activities that are happening. And it turns out you have a lot of bits and pieces of those in the fee schedule, but it's really hard. We have to build maybe like 5 of them, and they're underutilized because it's another thing you got to bill or code for. So can we at least make that easier? And can we layer more into that code set so that it starts to resemble something for primary care that is more reflective of the work and the level of effort? So that's a way of actually injecting more value into the fee schedule, which is, another way of kind of going about it, if that makes sense.
Yeah. And when I've talked to some of the providers I work with, I think one of the things that I've thought over the years is primary care doctors are closest to the patients and have the long-term relationships. So you view them as friends. So it's awfully hard to charge. And so I have heard physicians say their concern about the advanced payment models are patients still have a copay they have to pay. And that I mean, that's required by law. And I understand that. I don't think that's CMMI can't say, oh, we're going to waive copays for everybody. But in some way, paying for primary care is, my analogy is putting a coin slot on the dashboard, making you put a quarter in the dashboard of your car before you put your seatbelt on, because primary care saves money so many other places. It doesn't make sense to put that in there, but there they're very reluctant to have the conversations because now we're putting them in a position they have to sell the advance payment to get that per member per month, essentially, from Medicare fee-for-service, and convince the patient it's worth that copay every month. And so I don't know what the answer is there, but I would hope if somebody's listening that has the ability to do something about that, to look at opportunities to not have copays as part of that and structure it in such a way that patients have access to it. And it just becomes part of the Medicare model.
We've got populations, especially with underserved populations who, they had these exciting models, companies come in, provide team-based care, and then suddenly things change. The work and the effort that it takes to earn trust with a patient getting primary care in a high quality primary care setting rather than getting primary care at the emergency room because of all the access issues, that value of earning trust, like, hey, in this particular situation, we can waive that copay, and there's nothing illegal going on here. The patient was going to the hospital anyway.
Yeah, I think that was probably that is the biggest barrier that you just laid out, Dr. Shannon. And that was like a major concern and continues to be. And I think in this year's physician fee schedule, I have not read it all, but I believe there is acknowledgement that the cost sharing is an issue. And as you're talking about just, many of your colleagues who might work in, either smaller communities. Actually reminded me that my father-in-law was a general surgeon, so not primary care, but in rural areas, oftentimes like delivering babies and doing other things, and had plenty of uninsured patients. And some of them would pay him in services. So they had furniture, like a swing in their home that someone had built because they couldn't, pay the full bill. So it just reminded me of that. But yeah, this is how a lot of practice, these physicians are part of their community, and they're caring for people that are their neighbors and go to school with their kids' friends. And so it's real to say, look, I can offer you this set of services, and you're going to have to pay 20% of the cost is significant, especially at this time where we know a lot of people in this economy with inflation, et cetera, they're struggling. And when we're talking about Medicare beneficiaries, they're on fixed incomes. So 100% agree. You already referenced that this is like a statutory issue. It's a law. And so that is one area that I think when it comes to advocacy on the Hill, and if there is going to be physician payment reform, which a lot of people think there could be in the next couple of years, given that, we're not getting inflationary updates to physician payment, that something that should be put on the table. And we know that the Senate Finance Committee and some other members are really interested in primary care payments specifically. And to me, that is just kind of a no-brainer as something that, we need to remove the statutory barrier to that happening. And of course, you want to make sure there isn't going to be any fraud or abuse once those waivers are waived, or, if primary care copays are waived, creating safe harbors for folks that are using it to provide access and care to folks. I totally agree.
A couple of weeks ago, we were at National Conference, and this year I was so impressed by just the level of understanding that the residents had. The residents who were there, they're recruiting the medical students and all. I was pleasantly surprised to just see how young residents understood these different models, with the value-based care models and even with the direct primary care. So I feel like this new generation of young doctors are much more savvy than I know for sure than I was. I just wanted to get out and see patients, but it's not that simple anymore. So for these young doctors who are just, they're just coming on their own, what's one piece of advice that you could give them to help drive transformation at their level?
Well, first I'll say that's so heartening to know that, young physicians are coming out and, maybe fluent in some of these concepts because they're the future. And so that, even if it's not perfect, being engaged and being informed means that your opinion and you have an opportunity to try to make things better. So I think when it comes to a lot of these models, it's so easy to get caught up in the acronyms and are you at risk? Are you not at risk, et cetera. And all of that is important. But to me, at the end of the day, it boils down to is practicing under this approach, whether it's a model or a program, whatever it is practicing under this approach going to help me and my care team take care of my patients better, right? And is it economically going to allow me to continue to provide care to as many of the people in my community as possible. And that to me is like the key. And I say this a lot when I talk to folks about like, what value-based care is. I had a conversation just yesterday. I met some new academics who are, really thinking about, what is value-based care working? Is it not? It's not working. Maybe we should, and I'm like, well, at the end of the day, when I think about like, what should value-based care be solving for? And to me, it's really simple. Is it making the delivery or the receipt of healthcare simpler for the end users of the system? At the end of the day, the end users of the system are the patients and the providers. And, to me, it's like, is it making it easier for you to do your job, to get your patients what they need? And if the answer is yes, then that's how you should want to try to practice and improve upon it, because it's not perfect.
Yeah, that's for sure. It's messy. It's a lot of repetitive things that we have to say over and over again, especially in the early stages of earning trust, that, hey, we're your trusted place that you can come to. But no, I really thank you for taking the time today. I'm sorry about the technical issues that I've been having, but I really appreciate you taking the time to join us today and talk with us about this.
No, I was really excited. I ran into you guys. I think it was at an event back in May. I got to meet you both in person. You're like, oh, we'd love to have you on the podcast. And then like a couple months went by, and I remember, and I was like, oh, I guess maybe they didn't really mean it. But the email popped up. We made it happen. But thank you. Thank you so much. This was really fun.
What are your thoughts on raising the bar in value-based primary care payment? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.